Welcome to Chef AJ Live. I'm your host, Chef AJ, and this is where I introduce you to amazing people like you who are doing great things in the world that I think you should know about. My guests today are Dr. Doug Drossman and Johannah Ruddy. They've written a new book. They've actually written two books. They've been on the show before for their first book, Gut Feelings, and I'll link to that show right below this one. But they have a new book called Gut Feelings, The Patient Story, and they're going to talk about it. And fun fact, Dr. Drossman was the instructor to Dr. Will Bolshewitz, who's been on the show many times and is a personal friend. He's written wonderful books called Fiber Fueled and the Fiber Fueled Cookbook. And Dr. Drossman was his instructor during fellowship. So please welcome them both to the show. It's nice to see you again.
Thank you. Nice to be here again.
Yeah, thank you for having us.
It's my pleasure. But listen, I got to just, when there's an elephant in the room, are you sure you're not Christopher Walken's brother?
No, we don't. No way. But people have said it before.
You look like him. You sound like him. And I know people are going to ask Dr. Drossman, where'd you get the giant poop?
It was actually a gift from my dog. It was a dog pillow, and I stole it from him, basically.
Well, I think every gastroenterologist should have one. So why the new book? How's it different than the first book?
Well, we can talk a little bit about that in terms of the slides we have to try to introduce that to you. Glad to talk about how we got together. I don't know if we've been together on your show before.
I think you have.
Together. Okay. Well, then let's go on and talk about the book. I'm going to share some slides. Can you see that okay?
I certainly can.
This goes back to the practice where for many years I've been involved in communication skills, teaching doctor-patient relationship, and got struck by these comments that patients made to me spontaneously in my practice when they came to see me. Doctors don't believe me. You don't think it's in my head, do you? A lot of this issues around not being believed, being stigmatized, not feeling that their complaints are credible. And that led us to, for me to anyway, recognize that we've got a problem in our healthcare system. We have a problem because there are increasing demands on doctors to see more patients in less time. Insurance, as a gastroenterologist, I could do 4 colonoscopies in 2 hours and make 5 or 6 times more money than seeing a patient. And then we have the electronic health record. And here's a fascinating study just over an 11-year period showing that the face time with the patient in clinic is half what it was in 2005 compared to 2016. And the administrative time doing EHR and desk work has tripled. So what are we going to do about it? How can we be efficient? And that, in association with my work with Johannah through the Rome Foundation, through our communication skills training, and as a patient initially, led us to write a book about these disorders and how patients and doctors can talk to each other. So it was called Gut Feelings, Disorders of Gut-Brain Interaction, and the Patient-Doctor Relationship. So that book was the basis of talking about what these disorders are, what they mean, why is it that doctors don't give it credibility? And then we talked a great deal about communication and how patients should be talking to doctors and vice versa. Now, in that book, Johannah told her medical story of how she was treated. We'll get into that a little bit later, but how she was kind of dismissed by doctors, not diagnosed, not followed up, came to see me, things changed. And her story about the revelation she had really hit a chord with so many people out there. And so people harmonized with her story. And then what we decided to do was to do a book on other patient stories that I had seen. So this was called Gut Feelings, the Patient Story, Personal Accounts of the Illness Journey. And what we asked them all to do was to talk about their own illness. How did it begin? What was their experience with doctors? And how are you doing now? And then we did a video of them. And then I gave a perspective on my care with them. And then Johannah gave a perspective on her view as a patient advocate. So that's how the second book really occurred. And we can talk a little bit about some of those cases. But we tried to break away from this disconnect, which is the dismissing of illness when patients don't have any structural abnormalities. This is from the New Yorker, I'm sure you can tell. The patient has GI complaints. Nothing is being diagnosed by endoscopy. And the internist says the old body checks out. Let's see what Doc Atkins makes of the old mind. And the psychiatrist is waiting expectantly. That's a dilemma that's commonly believed by patients and doctors. If you can't find anything structurally, it must be something wrong. So we're teaching about these disorders of gut-brain interaction, which is based on the gut-brain axis. And we can go more into that if you're interested, but we talk about it in the book. And then we talk about what we call the biopsychosocial model, which is how we have to look at illness and disease now, not based on an abnormality in endoscopy, but on the combination of factors affecting the brain and the gut. The early life experiences, your psychologic state, your motility in the gut, visceral sensation, and the like. So that's where we are. And I don't know, Johannah, if you want to add anything about how we got together before we begin with the cases.
Yeah, well, I mean, I always say that it was serendipitous because I had just moved to the state and was looking for a new position, and was really feeling frustrated with the idea of having to start my career over again in a new place where I knew no one, and also struggling with a chronic illness that had gone on for over 10 years. And so trying to figure out, a job that was going to be satisfying and provide for my family, but also one that I could do physically because I had, this pretty severe chronic GI disturbance. And I stumbled upon a posting for the Rome Foundation and applied, not knowing anything about Rome, not having a diagnosis, so not really thinking that what Rome Foundation did applied to my own health. And met with Dr. Drossman as a job candidate and got the job. And a few months into the job, we were having a lunch meeting with staff, and I was very restrictive in my diet because I was so sick, and everything, it seemed I could drink a glass of water and get immediate abdominal pain and bloating and distension and diarrhea. And so I was very careful about what I was eating and drinking. And so I didn't eat, and made some excuse about why I wasn't eating. And I recall Doug saying to me at the time, we probably should talk about that. And so it led to my becoming his patient, and our work together has grown over that, to me working with patients directly now as an advocate and helping them connect to providers who can give them good care, whether it's a gastroenterologist, a dietitian, a brain gut behavioral therapist, support groups and that sort of thing, but also in working with Doug in our communication work. So teaching patients how to advocate for themselves, teaching them how to communicate well with their providers to get the care that they need. And then, of course, helping doctors in turn understanding the patient's perspective and what it is that they need from the doctor. And so it's been really gratifying to be able to work in this manner with Doug as a partner in this sort of communication work and grow a curriculum and training programs that we travel and we do at medical centers. And I talk with patients every day online or through email. And so it's really been very satisfying and very much a huge part of my life now. So
maybe we should start with your story then.
Sure, yeah.
So Johannah first came in 2017. She has just gotten the job as executive director did come on as a patient because of what she said. Is there anything you want to add to the first point about your early experiences related to this?
Yeah. So I grew up in a very large multi-generational family. We all lived under the same roof. There were about 16 of us. So you can imagine it was a bit chaotic. And unfortunately in my family, there was a history of abuse, physical abuse, sexual abuse, a lot of trauma and emotional abuse. There was alcoholism and the like going on, leading to all of those things. So that was just kind of the world that I grew up in until I was about 13, 14 years old. So, took all of that with me, packed it away and didn't really deal with that, and just moved on with my life, being the first in my family to go to college and get a degree and go into the workplace, meeting my husband, having 2 children, one of whom was born with some pretty severe orthopedic needs and needing a lot of advocacy. He's had 12 surgeries. So I was able to do all of that very well, advocate for him, make sure his needs were met, do everything that I needed to do. But when it came to my own development of illness, really struggled with communicating with doctors and challenging the things that they were telling me to be able to get good care.
Because your early family influence was to be seen and not heard.
Exactly. Yes. Yeah. I grew up in a household where women were to be mothers and wives and not to have any real role in the family other than that. And no jobs outside of the home were encouraged. Education was not encouraged. It was very much a subservient role that I came from.
So there was that background of not being able to communicate effectively and was basically could be steamrolled by the physicians if they did not validate or believe her illness. So let's talk about how it first began. It began what we call post-infection IBS after a gastroenteritis. And let's play that.
My story begins maybe about 10 years ago now. I went out to eat on a Sunday afternoon with my family, which was pretty typical for us, and went to a local restaurant and ordered a chicken salad sandwich and potato salad, and it was delicious. And went home, started getting ready for the week, and a few hours after that started to feel sick, vomiting. It progressed worse through the night to the point that I had massive diarrhea, but the diarrhea then changed to just blood. The pain was immense. I have never experienced pain that bad in my life. I was feverish, shaking uncontrollably. I really thought I might be dying. I had no idea what was going on. And we went to the emergency room. They immediately saw how sick I was and tried to manage the pain, immediately put me on some IV fluids and pain medication, which helped. But honestly, it really just kind of dulled it. It was still very, very painful. They came back in and told my husband that they needed to transfer me from the ER to the main hospital downtown because they saw in the CAT scan that my intestine was so inflamed, it was starting to close, and they were concerned about losing blood supply to my lower bowel. It was about a 45-minute ride. Of course, in the course of the ambulance, I'm still having massive amounts of bloody stool, and it was just so humiliating.
So her story is that she had E. coli hemorrhagic gastroenteritis. Doctors are very comfortable dealing with blood in the stool, inflammation of the bowel. But what then happened is after she recovered, it caused her to develop post-infection IBS. So she continued with pain and continued with diarrhea, but the studies were negative. And let's take a listen here, and then maybe Johannah can say more about what it was like, about how she was treated after the recovery.
So I saw my general practice doctor because I thought, well, maybe he could help me with that. But he could not. So he looked at my chart and all of my tests and was like, well, everything was normal. I think it's probably just stress, and you need to just try and relax. Tell me about, you have a stressful job. I know you have young kids, and that's just part of being a mom, and just related everything to my lifestyle, and told me that I should take some probiotics and I could take Imodium and over-the-counter diarrheal medications, which, like, to me was insulting because of course I had already thought of that. Of course I was already doing that. That wasn't why I was seeing him. I was trying to get a more definitive answer. And he never said, I don't know. He just said, have you tried this? Have you tried that? Drink a lot of water, that sort of thing. I think it was really disappointing because I felt like in just a blink of an eye, my life had changed. But it wasn't normal, and that wasn't how my life was before this all happened. So nobody seemed to care about that. Many of the doctors that I saw were not like that, but their communication skills were just inept, and they just really, they didn't know what was wrong with me, but they weren't willing to admit that to me for whatever reason. I would have much preferred someone to say to me, Johannah, we understand that this is really frustrating for you, and certainly understand how this is impacting your life. Unfortunately, I just don't know what's going on, and I don't want to continue to send you for additional testing because everything that we do comes back normal. So I'm going to research someone else who might be able to help you, or I'm going to send you to this place, or whatever. But that's not what I got. Instead, I got just pass you off with some Imodium and some water, and try some yoga, and see you later. So that just contributed to my further withering within myself, which I really felt like I was withering away.
She was perfectly fine until she got sick. She got a real disease, an inflammatory, infectious disease. And the residual of that was this IBS symptoms, which were just as severe. And she was treated differently. And that's what we're trying to get at. Why do doctors not recognize this as real? Anything else you want to mention about that, Johannah?
I think that when I look back on that, the thing that really stands out to me is not the lack of a diagnosis or an understanding of what was going on, but the real stigmatization that I faced and felt from every provider that I saw, whether gastroenterologist or in internal medicine, family practice, et cetera, was really this, what was communicated to me was because I was a woman, because I was a mother, because I was a wife, because I was working a stressful job, those were the reasons why I had the symptoms that I had. There was no other explanation for it. And also, could my description of my symptoms really be as bad as I was letting on? Might I be exaggerating a smidge because I'm a woman and I need attention? That was the stigmatization that I was dealing with every provider that I saw. And it became so frustrating and angering that I just stopped seeking healthcare because it would, I was taking time off of work to go to these appointments. Insurance wasn't covering very much. I was paying out of pocket, and I was getting this continual cycle of, we don't know, nothing's wrong with you. It's all in your head. Please leave us alone. Please stop bothering us. And I really thought, okay, I'm going to adapt my life around my symptoms and try to figure it out myself. And I think that was the most disappointing thing to me, because we as patients look to doctors as the people who are going to give us the answers and to help us get better. And I just wasn't getting that. And that was just so frustrating. And I started to actually think and tell my husband, like, maybe I am to blame for this. Maybe I did something wrong, but I didn't know what to do differently. I couldn't quit my job and give up my children, that's not an option. So it was very frustrating.
When you don't have a disease that they can adequately label, it's not as real. And I think that's where the change was. There were medications you got when you came to see me, but it was also the validation. Let's
Correct.
play that. And this indicates really what made the difference for her.
My husband got transferred, so we had to move across the country. I did not think that I should immediately go out and try to find a doctor to help me because I just had kind of given up hope. My husband says to me, you know, you work for someone and other doctors who might be able to help you. Maybe you should talk to him about your problems, your symptoms. So I was like, yeah, I guess you're right. And sure enough, they were able to help. Finally got a diagnosis of what was going on with my body. And looking way back at the beginning of this story with that chicken salad sandwich, knowing that it was an infection that had caused all of these problems. And so post-infectious IBS with diarrhea. And so that was really exciting. I mean, not exciting that that's what I had, but exciting to finally have a legitimate diagnosis and to know that I wasn't crazy and it wasn't all in my head and that these symptoms were real. Everything I had gone through was real and that there was hope to treat it was beyond exciting. Having that conversation with the doctor, knowing that he knew what it was and he had a plan to treat it, but also that he understood the impact that the past 10 years had had on my personal life, my professional life, my family, my marriage. He understood all of that, and that was all part of his treatment plan for me, which I had never experienced before. I was treated with rifaximin for the post-infection, which resolved the diarrhea within about 7 days, which was really great. And then for the pain, he gave me Cymbalta, knowing that my pain was just dysregulated because of all of the years that I've been suffering. And that's been remarkable. I was really surprised that he had a treatment plan for me, but also really, really excited that it worked because I had never had any hope that I would feel better.
Anything else you want to mention on that?
No, I mean, I think that understanding, I think the other thing that you did for me, Doug, was that you provided a lot of education for me about the symptoms, why they were occurring. You gave me a lot of really good scientific information that I never had, which again helped to validate my symptoms and make me really understand what was going on, which I truly appreciated. I think a lot of patients really desire to be educated about what's going on with their health. And it's really hard to find credible scientific information. And so we do a lot of Google searches and we do a lot of, we find a lot of nonsense, and that can be very confusing with all the stuff coming at us. And so I really appreciated you giving me really good evidence-based education that was part of the therapeutic process, as well as just your empathy and your care. So
that touches on what are the things that make a difference. We did, Johannah and I, along with some other investigators, did a study when we did a workshop at Johns Hopkins, and we asked a cohort of about 140 patients, what are the factors in the physician-patient relationship that gives them overall satisfaction with care? Maybe you want to speak to the findings, Johannah.
yeah, well, it was no surprise to us to see these results from the patients of the things that they felt were the most important that contributed to their satisfaction with their provider. Clearly, someone that they like is important. Knowing about the case for the provider to have done their due diligence and reviewed the case beforehand, accepting feelings and point of view, being available, responsive to questions and concerns, checking to make sure that they understand the diagnosis or the treatments. Someone they can trust, I think, is also, as you can see, it's really important, and someone that they felt connected to. Friendliness, humorous, honesty, being someone they respect. And then on the conversely, looking at things that really were negatives, were not doing a physical examination. We hear that a lot from patients. Personally, I saw probably 7, 8 doctors, never received a physical examination from any one of them that I saw. So that's truly important. It really contributes to the therapeutic process, helps patients to feel like, due diligence is happening. For other negatives, providers interrupting, seeming as being rude or unconcerned, or seeming to be rushed. All of those things were negatives for patients in terms of their satisfaction with care.
So I think that you can see that there's some commonality here, which then harmonizes with our book. So let's go to another case. This is Allison. And Allison is a nurse educator. She had a combination of, many of these patients have complex illnesses. She had irritable bowel syndrome with constipation, but she also had some gynecologic issues that we also were dealing with and also with the gynecologist, interstitial cystitis and vestibulitis, which is a painful, the vestibule, or the area around the vagina, was extremely painful, even to wearing underwear. And she had that as a young person. And then she also got IBS. And we can talk a little bit about how she did with all of this. This is her story.
Tell us how your illness began.
Well, my illness began, I'm going to take us back a little bit, prior to the GI illness, because it is relevant to the journey. I was 19 years old. This is back in the early 90s, dating myself here a little bit. And I had been diagnosed after months of trying to figure out, and I was lucky with this only being months, because I happened to live in an area where their research was being done on both interstitial cystitis and vulvar vestibulitis, or vulvodynia, as sometimes it's referred to as well. And those are both very painful chronic conditions. There is a hypervisceral pain response to any stimuli, very hard to control the nerve pain, 10 out of 10 constantly. And at the time, really no treatments.
The reason why it's relevant is that those are symptoms reflecting disorders of hypersensitivity of the skin, of the bladder, and with IBS of the bowel. Now, her symptoms began, her GI symptoms, in 2007. She had an operation for a severe condition called the cecal volvulus. And then what that means is that the bowel twists on itself and it's life-threatening. And she had to have surgery. And having the surgery injured the bowel to a degree that she became the nerves became hypersensitive, meaning that a little bit of stretch of the bowel with food or stool would cause pain. And that was the beginning of her IBS. But because she had a history of surgery, she was fearful maybe it's another bowel obstruction. And she developed what we call hypervigilance, or fear of that. So let's hear about that.
What you were dealing with was a level of hypervigilance because of this fear to your bodily sensations.
Yes.
And the doctors had hypervigilance because cecal volvulus, as you said, is a life-threatening illness. And they didn't want to make any mistakes. So that led to this endless number of studies which never disclosed an obstruction.
No.
Right?
But
Yeah.
it didn't make me feel any better, and it didn't take the fear away.
Nor the doctors.
No.
Okay.
And I think from the doctor's perspective, I think it was difficult to not have answers for me either, and to watch me suffer and be in pain and have no way to really help me, because there was nothing structurally that could be done. And that's when I was finally referred to Dr. Drossman when you were in the hospital system at the time, which changed the trajectory of this illness completely. That was a pivotal moment, and I'm grateful that that doctor was aware of you and realized that I needed more than he could provide.
So to put that in perspective, she and the doctors were always worried she would reobstruct, but they didn't recognize that she had hypersensitivity related to the IBS, and so they didn't treat her properly, and she kept seeing doctors and getting more tests. This heightened her fears. She basically was lost. Johannah, anything you want to add to that, or should I move on?
No, but I think well, I guess, yes. I say no, and then I talk. Hypervigilance is actually really common amongst patients with pain conditions. Once your brain has kind of become conditioned to this chronic pain cycle, you start this anticipatory behavior where you assume that you're going to have pain with every new experience, whether it's a next meal, whether it's a next activity, whatever. And then that, as we're going to hear next, leads to this catastrophic thinking, this conditioning that it's going to be so bad that you're going to end up at the hospital, or it's going to be so bad that you're going to, have a bowel movement in the car on your way to work, and it's going to be devastating, and you're going to be humiliated and have to quit your job. It's that kind of massive catastrophic thinking that occurs, and it's so common for so many of us patients with these conditions. And we'll talk a little bit later about how to handle that and treatments to kind of help change that maladaptive thinking.
Okay.
Were there other elements that were going on that were helpful to you? Because we're also thinking of what you convey to others about what they should be expecting or want in a visit.
I think for me, in terms of what I expected and wanted and what I received really was, if me continuing to go back to the same doctor over and over prior to you, over and over and over, and get the same answers. There's nothing wrong. We don't know. We don't know. We don't know. I could have given up. I could have stopped and said, I guess I have to live like this. Nobody knows what to do with me. But I didn't, and I wouldn't let myself stop. Like somebody in my mind, somebody has to know. I can't be the only person in the world experiencing what I'm experiencing. Somebody knows what this is, how to name it, and how to help me get it under control and not live in this fear all the time. So I think one of the biggest messages is really to empower yourself. I tried to learn as much as I could learn on my own. I read my medical records. I read my charts. I requested all of those. So I had an understanding of what was happening, what had happened in the past and the tests that had been done and the results and all of that. And I think just never giving up, because somebody somewhere does know the answer and they can help. There is help out there. You just can't give up.
So that the next thing would be, how do we maintain the care?
But once that relationship is established, the visits can be spread out because you know that the availability is there.
Right.
I've had experiences with patients where they would call on an emergency basis very frequently, but once we set up regular visits, I've had them come to me and say, well, I really was going to call you at night, but I knew I had an appointment in a week. So that kind of relationship is important, and it's something that isn't always time-based, but
Right.
relationship-based.
And I think the important piece there is you have to trust. There's a level of trust there, and you trust that you have that appointment coming up. And I see that playing out for myself now, something always happens. You know, and then it's an emergency and trying to squeeze me in. Whereas if I had that appointment, probably wouldn't panic. So I think that was huge, and the teamwork.
So how did we treat her? We basically, let's see how we dealt with her, how it managed her
I would
symptoms.
say the GI currently is pretty under control. The pain is well managed. There's a new medication that I'm going to start, which I haven't started yet, but I manage with the SSRI and with the tricyclic helps manage the nerve pain. So most days, my pain is, a lot of days, my pain is 0. Some days my pain is 2. Sometimes I would say, I mean, there are days where it goes up high, but I don't panic. I don't catastrophize anymore. The volvulus happening again, thought doesn't replay over and over. It still pops up every now and again, but it's kind of easily quieted. I think what helps me is yoga, meditation, walking outside, I think is huge. Being out in nature just makes me feel good all over, mentally and physically. So I try to take care of my mental health as well as my physical health. Those medications play a big role. From a dietary standpoint, I've learned sort of what I can and cannot eat, what will contribute to motility issues one way or the other.
So that's her story. And she, like many of the other patients, were caught in this really vicious cycle of having symptoms, not being validated, requesting tests, maybe having unrealistic expectations. The doctor gets frustrated. As she pointed out, we can't help you. We don't know that anything's wrong. The relationship is what makes the difference. Being with the patient and working with her through the symptoms, rather than trying to find some miracle diagnosis. She has a diagnosis, but they don't recognize it. So she gets more tests, more referrals, and this leads to the hypervigilance and the symptom-related anxiety. So that's her story. We do have one more. Should we go to that one, Chef?
Yeah, that would be fantastic.
Okay. This is Alex. Now, I'll be clear with you, Alex is not better like the other 7 patients. We're still working with him because he's had very complicated conditions, symptoms, and he's had combinations of anxiety and GI disturbances, and we keep trying to figure out the best solutions. He's in pharmacogenomic sales, so he works with drugs. He has 2 conditions, one called functional dyspepsia, and the other called IBS and anxiety, and he has what we've called abdominophrenic dyssynergia. I don't know if you've heard of that, but it's so common in GI now where patients, most often women, but males too, develop swelling of their abdomen. They say they're like pregnant, and it's usually after eating and the swelling comes on and then it goes away again. And that's related to these GI, functional GI disorders. Well, this guy also developed his condition after traveling. He was in Israel, I believe, and he got a Middle Eastern respiratory virus and a secondary bacterial infection. And like Johannah and like several of the other patients, once it got better, the sensitization of the bowel continued, and he continued with symptoms.
Well, tell us how your illness began.
Sure, yeah. So my illness began about the age of 20 when I was a sophomore in college. I had just returned abroad from a trip with some friends in college, and came back with MERS, Middle Eastern Respiratory Syndrome, bronchitis, sinus infection, took multiple rounds of antibiotics, and after those rounds of antibiotics, started to have some weird GI issues. Went back home to DC, where I started to be on treatment, and that kind of started that journey of trying to figure out what was going on with my GI symptoms.
You know, for the audience out there, this is a very common theme, getting a severe infection and ending up with what we call post-infection IBS. What were the symptoms when it began?
Yeah, so immediately, any type of food that I would eat, I would immediately get full, I would get bloated, it would turn into pain, some nausea. I didn't really have much appetite and really felt like I was walking around with food constantly stuck in my stomach throughout the day. And it definitely was very bothersome and very scary, especially as a young 20-year-old, not knowing why this was happening and what I was going through.
So you never had this before?
No, yeah. I mean, I could eat a whole Chipotle burrito, maybe even two, and was completely fine up until that point. So no GI issues whatsoever up until that time.
So for those of you out there, this is not IBS. This is postprandial or after a meal fullness, early satiety, meaning feeling no longer hungry and not even able to complete a normal meal. And that is called functional dyspepsia. And it's a little bit like PDS, postprandial distress syndrome, but there's also a component of pain. Was the pain only after a meal, or did it continue?
Yeah, so the pain was usually right after a meal, but it would continue throughout the day and even into the next morning sometimes.
So just to tell you what post-functional dyspepsia is, we think about IBS, where you have abdominal pain and diarrhea, lower pain, diarrhea or constipation. This is more upper gut. They can have pain, they can have burning, or they can get full very easily and get bloated, or they can have fullness in the abdomen. And so there are different types of this, and it's the upper gut. But similar to IBS, it can occur after an infection. So he developed these disorders. He saw many doctors. Again, what we're learning is a doctor saying you have this disorder is amazingly therapeutic, as opposed to saying we don't know what's going wrong, what's wrong, let's do more tests. He felt unheard, the same story. The doctors didn't really give him a diagnosis, and he didn't get proper treatment.
Before seeing you, I had lost all faith in the healthcare system. I had lost trust and faith in all doctors. I didn't trust them. I didn't think my voice was ever going to be heard. I didn't think I was going to be seen again by any type of doctor or even specialist. But my first visit with you, I think it lasted over 2 hours. Honestly, to this day, I'm still shocked by it all. It just brought me so much hope. You listened to my concerns, you listened to my whole history of my entire life. No doctor had ever done that before. And it just brought me so much hope to know that you weren't going to dismiss me. You were here to listen to all my concerns. You were going to treat all of my aspects of my illness. And you gave me not just one diagnosis, several diagnoses. And just knowing that, even beyond starting the treatment, I mean, we're so relieving. And I remember driving back home to DC after that day from your office, I broke down in tears. I think my parents cried too. Usually there were tears of sadness, throughout my healthcare journey, but this was the first time in a long time that there were tears of joy and tears of hope.
You know, I'm not doing anything magical. I know there's a lot of attribution towards what I did, but the whole purpose of the book is to teach what are the elements that doctors can do to listen, to validate, to make a diagnosis. And so, as I said, he's been more difficult to treat because the medications we used gave him some problems, one of which is serotonin syndrome, where there's too much serotonin in the medications. And so we've had to adjust the dosing to get him a little bit better now, and we're still working with it. I think the last part to mention, Johannah, do you want to add anything, by the way, to this?
No, not at this point. Maybe at the end, when we're finished.
Okay. So I asked him, what is his message for patients? Even though he's not completely better, he's still coming. We're still working on this.
Do you have any messages for the people out there, either patient or doctor?
I do, yeah. I strongly advise for patients just not to give up hope and to advocate for themselves. There are plenty of providers out there that are willing to listen, and definitely surround yourself with friends and loved ones. That's definitely extremely important. That has been important through my journey. And to keep advocating and to keep fighting. Don't give up. If you get misheard, don't let it get to you. Move on, find that next provider that is going to be the one that's going to help you and going to listen. It took me 6 years to find a provider like yourself that was willing to listen and help me through my journey. But it was from not stopping and not wanting to give up. So my best advice is to not give up, surround yourself with loved ones and friends, and look for that one doctor that is willing to listen and continue to advocate for yourself as a patient.
How about for doctors? Anything for doctors?
For doctors, it would just be to listen. I know it's tough for a lot of providers that, they have a lot of patients, they don't have enough time, but just being able to listen to what their patients are going through and understanding their exact symptoms and not disregarding them, I think is extremely important from a provider perspective. To understand and better help their patients, as a lot of times the providers have a narrow scope if they're looking for that one diagnosis, and if they don't find that, they give up. So I think having a more open mind from a provider's perspective and listening to your patients would be very important.
Okay, those are our stories. We could talk a little bit about that these are, we now call them neuromodulators, and the ones we often look at are the tricyclics. People are familiar with Elavil or amitriptyline. We tend to favor the SNRIs, duloxetine or Cymbalta. The important thing is that patients will often say, I've been on it 2 days and I'm not any better. And this graph kind of shows that the first week or so, you may not get benefit. In fact, you may get side effects. You have to wait a week or two to start to see benefit, and then the side effects diminish. And there are psychologic treatments. This is too complicated a slide to go into, but I want to point out that brain-gut therapy, brain-gut behavioral therapy, which is hosted by the GastroPsych group of the Rome Foundation, is targeting specific problems with specific kinds of treatments. Someone may be more amenable to hypnosis, others to cognitive behavioral therapy or stress reduction, and that can be depending on what type of factors are going on. So there are psychologists who work in the GI space now to help treat these conditions, where they basically personalize the treatment. It's not one size fits all anymore. And when you do that, you can combine medications with therapies, often in combination, to get some benefit. Now, as a result of the book, the patients were telling us, you heard what 3 of the patients told us. So what we did here is Johannah and I compiled what it was that the patients wanted. So this is kind of our own little evidence-based summary. The patients want the doctor to prepare to review the medical records prior to the visit. Several patients pointed out the doctors weren't prepared. To listen actively, to engage with good eye contact, and so the patient feels heard. To validate so that they don't think the pain is in their head. To establish a connection. Likability is one of the key features that was in our study that graph we showed you. Liking the doctor and liking the patient is a combination that is very successful in achieving connection and therapeutic. making a specific diagnosis. Johannah pointed out the importance of education using graphics. Working together, this is called patient-centered care. Providing treatment options, but the patient makes the final decision. So you weigh the pros and the cons, and then the patient decides. And then being available and providing continuity of care. So that's our story at this point. We have other ones, but we may not have the time. Maybe there are questions.
Let me look in the chat and tell you if there's questions. I have a question though, Dr. Drossman. This occurs a lot, you're saying, in the GI space, but this could occur in other specialties of medicine too, I'm guessing.
Yeah, we're seeing it in every area. And the ones we see it most are the conditions that are not explained by a structure. Fibromyalgia, migraine headache, chronic back pain, widespread body pain, interstitial cystitis, pelvic pain. It just goes on, particularly painful conditions, nausea, conditions where you don't see anything on x-ray. That's not to say what you see on x-ray and endoscopy is the answer. Patients with inflammatory bowel disease, they can have mild disease, but still have these symptoms. It's all relating to the brain-gut axis and the way the brain and the gut are controlling these symptoms.
Thank you. So there's a comment from a live viewer named, I gotta put my glasses on, I'm getting old. Mary, she says she had a similar story, undiagnosed H. pylori for 3 years, but because her symptoms did not meet the standard, she begged for an EGD and biopsy and then was finally diagnosed and continues to suffer with post-infectious diarrhea. So people are relating to this.
That's right. She got an infection as well. It was likely treated, but then she continued with symptoms.
Yeah. Wow. I feel like your work is really, the clinicians need to read your work.
Well, that's our hope. The first book is clearly for clinicians and patients. The second book tells patient stories, but the stories are for doctors. I don't know if you want to add to that, Johannah.
Yeah, I mean, they really are. It's interesting when we go to medical centers and we give these workshops. So much of what we're explaining and kind of telling them about the patient's journey is very new to them. Like, this is all like, I didn't know that patients were having this kind of an issue. We didn't understand that they were feeling stigmatized and unheard and disbelieved. And so it's very eye-opening for a lot of providers who, maybe they haven't participated in that kind of care. And so this is all kind of new to them. But I think for patients too, this second book provides, in my opinion, a sense of camaraderie. You just mentioned a viewer, Mary, who said she's dealt with the same thing. It's very common. And I think, we don't talk about it enough in the public space. And so there's still a bit of a stigma attached to, symptoms that are not very sexy: diarrhea, constipation, bloating. Those aren't things that people necessarily feel comfortable talking about around drinks with their friends. But we need to, because the more we do that, the more we break the stigma that's attached to them. And the more we find out that other people are having the same symptoms, have had the same experiences with their providers, and we can all kind of help and support one another in that regard. So that's why these books are so important, in my opinion, from a patient perspective, because it really gives, concrete ways of how to better your care with your provider, but also make you feel less alone. So many people think that they're the only ones suffering, and that's just not the case.
I want to tell you a story that relates to your point about doctors need to hear this. I was doing a session at the AGA, American Gastroenterology Association meeting, where I had 3 patients on the panel, and I was interviewing them about their condition. And the audience was filled with about 200 doctors. And one of the patients talked to me about how bad she was treated by her doctor. This was a doctor and is on the West Coast in San Francisco. And she went on to talk about, he didn't listen to me, he never validated anything. And the whole audience was rapt listening to all this and felt for her. The doctor was in the audience. The doctor was in the audience, and he actually said, "I'm so sorry you felt this way. You never told me this." She said, "You never asked." And it became a very poignant moment where doctors weren't recognizing how the patients feel when they don't get the proper care.
I think it's very intimidating for people, especially depending on their personality, because some doctors they have the aura that, I'm the doctor, you're the patient, I'm right, you're wrong. And it can be very hard, especially if people have HMOs where, like, if they're seeing a specialist, they have to wait months and get approved, and then they have a bad experience. You know what I'm saying? It's not an easy system to navigate.
100% agree with you. That is absolutely true. And for people who have trouble with authority and challenging authority, doctors are seen as authority figures. And a lot of us have a hard time asking questions or challenging anything that they're telling us. So I totally agree with that.
Yeah. Dr. Drossman, Mona, who's watching live, wants to know, do you do telehealth?
I do telehealth, but the nature of the patients I see are often complicated. So the first visit needs to be in person, and then we can continue with telehealth. So we treat half our patients from out of state or out of the country. I just got an email yesterday from Israel wanting to come down, and then we can continue the care. We also have good doctors from the Rome Foundation around the world. So in the back of the book has a listing of about 50 or 70 doctors around the world who do what we do.
That's amazing. How can we teach patients to advocate for themselves? Because it's not easy, I'm telling you.
It's not. It's like it's a learned behavior that takes practice. And I will be honest, the first couple of times that you do some self-advocacy within a physician's office can be scary. It can be a little intimidating and scary, and your palms might sweat and you might get really nervous, but it gets better with practice. And I'll tell a story real quickly. I transitioned out of care with Dr. Drossman. I'm doing well. I didn't need his high level of care for complicated patients anymore, but I did need a screening colonoscopy. I'm of age. And so went to a new gastroenterologist to get to meet with her for the first time and then get that scheduled. And I was so determined that I was going to self-advocate, and I was going to make sure that she was the right physician for me, right? Because there's someone that's going to be right for you, that's going to be your partner, and then there may be people that are not right for you, and that's okay. And so I was determined I was going to find this person after coming from such great care with Dr. Drossman. And so she comes in, and she, instead of her asking me questions, I start asking her questions. How do you feel about my being involved in the decision-making process of any treatment that we might need? How do you feel about, and I'm just like interviewing her to a certain extent. And I said, I'm looking for someone who's going to be my partner in my care. And, if you can do that and we can work together, then this is great. But if that's not something that you're used to and not something you're willing to do, then, this probably isn't going to work out. And she stopped and she said, no one has ever asked me these questions or requested that. And I love it. I would love for you to be, to partner with me. And so that was great. And so we continued the appointment and moved on. But that was so scary for me to ask those questions, but it really paid off. And had she said no, that would have been great too, because I would have known that she wasn't going to be able to provide the kind of care that I was looking for and that I needed. And that's okay too. So I tell patients, like, it's okay if you meet with a provider and they aren't the right fit. There has to be that fit. And don't be afraid of being accused of doctor shopping or being difficult. That's not, you want to find a partner, just like Dr. Drossman partners with his patients. And there are many other providers who will do that as well.
In the third section of the book, the first book talks about what patients can do when the doctor's being dismissive or seems to be looking at his watch or her watch a lot. So there are some elements that you can do that gives you that sense of a little bit more sense of control.
Right.
It's this hierarchy. It's collaborative care we're trying to establish, that it's a collaboration, and it's challenging. but that's what we're trying to do.
Yeah.
You know, I'm so happy that you put a male in your presentation, because my question was, is this something that is largely a female problem? Like, do you find that female patients are more likely to undergo this type of dismissive treatment than a male?
Yeah, well, you could start with the condition itself is about 65% female, higher, but in the offices, it's more like 80 or 85% female. But you're right, the women, men and women are treated differently. In fact, some of Johannah's work, which I think she's going to talk about now, addresses some of those experiences about why it is different for women and men. Maybe your own experience. I remember the accident you had.
It's 100% true, and it's informing a lot of my own research now. I'm in a doctoral program and looking at stigma in chronic health conditions, particularly stigma, gender-related stigma. Women are treated very differently when complaining of pain. And in the ER, there's many stories and data that shows that women are not given the same level of care. They are not believed when coming in and complaining of pain in the emergency room. Male counterparts will be immediately given pain medication, where women will have to wait hours and hours and hours before receiving immediate pain relief. And many women are seen as drug seeking or falsifying their pain levels compared to their male counterparts. It's quite astounding and frustrating if you've ever experienced this in a situation with a provider. But it's just the fact of the U.S. medical system, and there's a lot of reasons why that is, going back a long ways, looking at hysteria amongst females in the early medical days. And unfortunately, that stigma and that behavior is still very much prevalent in our medical system. It's far worse for women of color, unfortunately. So
I was going to ask if there was a racial or even an age bias too.
Yes, so definitely worse for women of color. Of course, outcomes for women of color, unfortunately, are far worse than white female patients for a lot of conditions, including mortality rates. So there's a lot of work to be done when it comes to addressing how care is given and equity in care for women versus men. But in GI or in these sorts of conditions in general, that, as Doug said, lack a structural cause, you see much higher levels of stigmatization in women. I'm thinking that it's psychological, having a psych consult called in before addressing the pain component, that sort of thing.
Oh boy. Well, Mary, who's watching live, wants to know, do either of you have any tips on how to find an exceptional doctor to help save time waiting for that first appointment and going through that time-consuming trial and error?
Get our book.
Okay, well, I put links below, and I'll put them in the chat again.
And Mary, you can email me. I'd be happy to help you and see exactly what your needs are.
Yeah. You know, Renee, I had to talk about this topic because this doctor talked about it the other day, and they said he was fat shaming because he was sharing some research. But Renee is saying there's a bias against overweight patients too. Would you agree, Dr. Drossman?
Absolutely. Overweight, alcoholism,
Yes.
the diseases, not behaviors of their behaviors, but their diseases. And age too. I remember being on the wards. If you have a large group of patients in your panel, the older ones tend to be put in the back because they're older. They probably won't live as long. I mean, there's a lot of things that go in one's judgment that's unconscious. But you're absolutely right. Weight, alcohol, drugs, age, and gender and race.
Wow. You know, this is just slightly off topic, but I always wondered my whole life, when you go see a doctor, why do they knock before they come in? It's like their house.
Yeah, well, it's part of giving the patient some level of respect. They're taught it in physical diagnosis.
Okay.
I
always thought that was so. It's like what is a patient actually going to say? No, you can't come in. I mean.
Yeah.
Have you been waiting for 2 hours?
Yeah, that's so funny. Hey, Dr. Drossman, since you are a GI doctor, would you mind answering a GI question that I think is kind of pertinent to what's going on right now from Apple? She wants to know, know of a link between gut health and recovering from long COVID. Have you done any research or noticed anything?
Yes, there is clearly, first of all, about 30% of people who get COVID get diarrhea or GI symptoms. And then in recovery, we're dealing with a very similar issue of post-infection IBS. In fact, Giovanni Barbara and some others have published papers on that now to show that long COVID can be associated with GI symptoms.
Great, thank you. And here's one from Mona, IBSC, that's irritable bowel syndrome, I guess, constipation dominant. She's following a healthy diet, like the one that most of the doctors on this show recommend, unprocessed whole foods. And she says she still sometimes goes 3 days or longer without a bowel movement, and then it's difficult. Any suggestions, stool softener?
Yeah, well, of course, diet can work so much, but some people may have slow motility in general. And that needs to be treated. Of course, the first option for general mild is people having more fiber in their diet, of course. But if you're having more significant constipation, we often recommend that you would use something like Miralax PEG solution, that you drink it and it increases the volume of the fluid in your bowel, and that can lead to a bowel movement. If you haven't gone for a few days, you can get an over-the-counter stimulant laxative like Dulcolax to get you to evacuate and maybe help reset your bowels. If you're still having consistent problems, then you can go to your doctor who can prescribe specific medications that are used to treat constipation.
Yeah, surely suggesting prune juice.
Prune juice, kiwi, good study showing that 2 kiwis a day can work very well. Prune juice does that as well.
Yeah, that's so interesting. This whole bias thing is, it's upsetting. People are saying socioeconomic status too. There's a bias of people. And I don't know how to fix the world. But on the other hand, unless a doctor does something egregious where, he really harms you, to complain against a doctor is very, very difficult.
You mean if the doctor does something really bad, how do you
Right, like if doctor does something really bad, like cuts off the wrong arm or something, that's different. But in general, if you feel like you've been dismissed or misdiagnosed or whatever, it's hard to complain against a doctor in this system, because also, even if the next doctor agrees with you, doctors don't want to go up against other doctors.
Right. Well, in the course of the visit, there are some things you can do. Nobody wants to be criticized. Nobody wants to say, you're not doing this right, pointing a finger. What you want to do is to say, I'm a little bit confused. I don't understand if what I'm saying is being heard. Can I repeat what I'm concerned about? Just to raise their level of attention is a way to break through some of that, because the doctors are probably focused on getting home for dinner. It's running late. They're not listening. So you have to kind of shake them up by saying, I'm not hearing this right, or I don't understand. Those kind of questions can help bring out the doctor's innate desire to help by saying, can you help me? So that's one thing you can do. But in the book, we talk about, even to the point of getting more assertive about it and saying, I don't think my questions are being answered properly, and really start to ramp it up a little bit. Of course, you can always complain to the North Carolina board, but that has to be the medical state board, but that has to be something pretty serious.
Yeah, absolutely. Here's a fun question from Kathy, because we started the show explaining that that Dr. Will Bolshewitz was a fellow and you were his instructor. And she wants to know, was he a good student, and did you know he would be up to great things, including, double New York Times bestselling author?
I didn't think he was going to go into his fiber fueled world, because we were dealing with different kinds of diagnoses and treatment, but he was one of the best I've ever seen of the GI fellows that I've had. We actually connected very well and hung out a lot together. Went for beers on Friday.
Well, he speaks highly of you, and he's actually the one that introduced us when I interviewed for the GI Health Summit. So that's fantastic. Well, this has been a wonderful conversation, and I'm sure there's many more to come from this. But I appreciate the work you're doing to shed a spotlight on this, because I know that people, I mean, I had GI issues and I know people suffer terribly because if it doesn't show up on x-ray, it must not exist.
Exactly. Yep.
Yeah.
Thank you for doing this. It's a credit to you to want to approach this area. with
Yeah,
your
no,
audience.
I do, because I feel bad for people that feel bad. And, it's just, I find it also, it's a very interesting topic. I mean, the whole gut brain connection, your work and Dr. Emily Meyer, that's just fascinating to me. So thank you, and happy holidays to both of you.
Thank you. Same to you.
It's my pleasure. And thanks all of you for watching another episode of Chef AJ Live. We have to start the show at 8 a.m. tomorrow, unfortunately, because my guest either had to cancel or start early because he is a professional musician, Billy Grislack, and he has lost a tremendous amount of weight following a plant-based diet. He's going to play music for us and tell his story.